All right, I'll get going. Thank you, everyone, for coming along. Good afternoon. My name is Anurag Sekra. I'm one of the consultant gastroenterologists here in Middlemore. And I'd like to thank the organizers to give us this opportunity to present our study on chromoendoscopy. Now, I do appreciate the Chromoendoscopy is a word which may not be familiar with you, so I'll try and explain that with you. But essentially, what we did in our study is looked at the benefit of chromoendoscopy versus the standard normal colonoscopy in detecting non-polypoid dysplastic lesions in people with inflammatory bowel disease. Now, just to give you a bit of background, with chronic inflammatory bowel disease, there's a significantly higher risk of colorectal cancer. And as a result, surveillance has been recommended for that. Essentially, IBD is considered as the third highest risk factor for colorectal cancer after FAP, which is familial adenomatous polyposis, and the second one is HNPCC. So essentially, after the genetic syndromes, IBD is the third highest risk factor for colorectal cancer. So if you look at the data as far as ulcerative colitis is concerned, the risk of colorectal cancer is about 2% at 10 years, and it goes up to 8% and further to 18% at 20 and 30 years respectively. So the cumulative risk of colorectal cancer in people with chronic IBD increases over time. And that's not the only issue. It's unlike the normal or the colorectal cancer. Otherwise, the histological grade tends to be higher, and as a result, the mortality risk or rates are higher in these patients as well. It accounts for about 15 to 20% reasons of death in patients with IBD. Because of the high risk of colorectal cancer disease, surveillance has been recommended, and it has been done now for more than 40 years, really. So what we used to do previously, we would do our standard colonoscopy, so we reach to cecum, and thereafter we'll do a slow withdrawal. And what we were really doing is taking biopsies, every 10 centimeter in quadrantic fashion. There was a huge problem with this problem. With this strategy, the issue was that you were not really looking at the dysplastic lesion. You were randomly taking these biopsies. And what happened was, if you took 33 biopsies, which was recommended previously, you would actually examining only 0.03% of whole mucosal surface, which was incredibly poor. And not surprisingly, the dysplasia detection rate was less than 2 per 1,000 biopsies. So the pickup rate was incredibly low. So that wasn't good enough. So then came along virtual chromoendoscopy. Now, virtual chromoendoscopy is something which is very easy to do in the sense that on the scope, you've got a button. You push the button, and it switches the mode to either NBI. So that's with Olympus, iScan with Pentax, and FICE with Fujinon. So we have either NBI or iScan in our department here in Middlemore. But this was not good enough either. So there was this, although it's an old study, but this is the best study I've found, which looked at it. It was a crossover study of 42 patients, which looked at this. And essentially, there was no significant difference. And in fact, NBI or virtual chromoendoscopy picked less number of lesions. So wasn't really employed at all. Then came along chromoendoscopy. Now, chromoendoscopy is essentially you spray the colon with dye in form of either indigo carmine or methylene blue, and then that increases pickup of dysplastic lesion. I'll show some data around it. But essentially what happens is that it highlights the lesions, and as a result, the pickup rate increases. How we do it? Well, we get to the cecum with normal scope, as we'd normally do, and then we have a water jet function, which is replaced by, so instead of water, we put either methylene blue or indigo carmine, depending on availability. I personally like methylene blue more, but regardless, you could use either, and that, as I say, increases the dysplastic lesion. This is a meta-analysis that came from 2011, and if you look at this, probably employed back in 2003, and they looked at the pooled analysis, and it favors chromoendoscopy. So apart from one study, all the studies showed that chromoendoscopy was favorable over white light endoscopy. then a group of experts sat down together and they ran their own meta-analysis. So this was called the scenic group, and most of the guidelines along surveillance of IBD is now followed as per scenic guidelines. And again, what they showed is that chromoendoscopy was better in picking up these dysplastic lesions for surveillance of IBD, and they did recommend using that as well. Now, if you look at worldwide, what's been happening, so if you look at the guidelines prior to 2008, they did not mention what type of technique to use. But if you look at ECHO guidelines, which is Crohn's and colitis group in the Europe, or the British Society of Gastroenterology, they have recommended chromoendoscopy, and subsequently American guidelines have suggested that as well, and a few other nations as well. Well, how are we doing? So these are the guidelines from 2011. And what they are saying is essentially that well, it's 2011, so it's quite old to begin with. And what they say is that chromoscopy is not currently available in New Zealand. This, of course, is not true, because it is now. Certainly, maybe back then it wasn't, but it's quite widely available now. And they were using terms like DALMS. Now, this is a term which was used for these kind of lesions, which has been fallen off, and I'll talk about that in a minute. But essentially, this has fallen through, and this is partly incorrect now. So just wanted to mention that. Now, when we pick up these dysplastic lesions, this is how we report it. The key question is whether the dysplasia is visible or not, and whether you can resect it endoscopically or not. Because previously, if you pick up dysplasia because it's invisible, it's random, all these patients will end up in colectomy, which has significant morbidity and mortality. So now we can, with chromoendoscopy, we can see the lesion, and not only see the lesion, we can actually remove them. And as a result, these patients can stay on surveillance rather than colectomy. So that's a change. And what these scenic people suggested is just you try and remove these and remain on endoscopic surveillance. And they did not suggest doing any NBI and instead of colectomy, just as I say. And if the lesion was invisible, and that's more pertaining to standard colonoscopy, if you did pick it up, then it should be referred to a specialist who can do chromoendoscopy. Okay, now I want to come to my study now. We have no local data thus far which looked at chromoendoscopy, so we thought we'll have a look in there. We investigated 110 consecutive patients between the specified time period and compared patients who had chromoendoscopy versus the white light endoscopy. So we had 35 patients who had chromoendoscopy and 70 white light. We sat with our statistician and we used the Poisson model here. So these numbers gave us enough power. We used Olympus, and as mentioned, methylene blue or indigo carmine was used. So just quickly going through this slide, we looked at the baseline characteristics and was quite similar in both the groups. And we looked at disease extent and things like family history and primary sclerosing cholangitis, because that increases the risk of bowel cancer in these patients. Okay, so this is my key slide here. So we looked at the non-polypoid lesions, so lesions that are less than 2.5 millimeter in height were called non-polypoid dysplastic lesions, as they are worldwide. And if you look here, white light endoscopy, so that's normal standard colonoscopy, did not pick any single lesion, as opposed to chromoendoscopy. They picked 12%, so 4 patients out of 34 had this. And number of lesions were 7 in total. So these were statistically significant. If you look at polypoid dysplastic lesions, the pickup rate was quite similar, because you don't need special stains for raised lesions. They're quite easy to visualize. And these are this is the histology, and essentially in first 3 patients, we could manage them endoscopically. 4th patient had 2 lesions which could not be managed endoscopically, so end up in surgery. So these 3 patients are still going with surveillance and are doing quite well. So in conclusion, our study shows that with chromoendoscopy, there's a significantly higher non-polypoid dysplasia detection rate. And what we suggest is, with this high quality international data available, and now with local data confirming the same, that we should implement these changes in the guidelines for colorectal cancer surveillance in IBD patients in New Zealand as well. Thank you very much.